Good evening. We can again IPDI meet the expert session 10. We are really excited with us for a special guest, Dr. Jack Ten. You know, everybody is our good friend of Bangladesh. Dr. Ten is a doubly accredited cardiology and intensive care unit in Singapore. You already know he is the past president of APSC, and now he is the director of Emerging Leaders Program of APSC. He's working on, you know, in the National Heart Center of Singapore on the Sengkang General Hospital. And also our special guest, Professor Abdullah sir, is the Secretary General of Bangladesh Cardiac Society. I'm requesting Dr. Jack Ten, please give the inaugural speech. Before that, I'm requesting Chairman of IPDI, Professor Abdul Wadud, please opening remarks and start the session. Today's session is, you know, OCT and beyond. Our guest speaker, you know, Chee Yang and also Arun Kalyanasundaram. Dr. Abdul, please start your session.
Good evening, everybody, and welcome to this session of Meet the Expert. Today, we are going to have a session on a particular type of imaging, OCT basics and beyond. Why are we doing that? This is something not have enough presence in this country, but we are starting to have this facility available. And very soon, we hope that it will be available in many more centers. And for that, we have to know why we are rooting for this particular imaging. Today's lecture that will be given by Dr. Chee Yang about the basics, and our good friend, Dr. Arun Kalyanasundaram. And he will show a live-in-box case and show particularly why we are really interested in this imaging method, which will actually improve the quality of our performance during the PCI. Welcome, everybody, and our speakers. I hope they will enlighten us very much in this regard. Mohsin, you can go take over.
Thank you. We have the expert panelist here. This is Professor Abdullah sir. Also, you see Professor AQM Reza, Professor Khaled Mohsin, Professor Chowdhury, Professor Said Rahman Khan, Dr. Kaisa Nasrullah Khan, also Dr. Ashok, Dr. Dhiman Banik. We are really miss our Professor Jamaluddin, is also in the Holy Hajj, and also Mumin Zaman is attending the Hajj. So I'm requesting Dr. Jack Ten, please give the English speech to the session. Dr. Jack Ten is the good friend of Bangladesh, also leader of Emerging Leaders Program. Dr. Jack Ten.
Thanks, Professor Mohsin and all the esteemed professors from Bangladesh. I'm very privileged to just give a few words of remarks before we start this session. I think we always underestimate the need for intravascular imaging, especially when we do our intervention. I think even the best of us can't see what happens inside the vessel. And I think coronary angiogram itself is a great tool, but it's still not good enough when we want to have a well-optimized result. I'm very happy that you have put together a very exciting program. And I'm very glad my colleague, Dr. Chee Yang, who had a great exposure in Colombia, is able to speak to OCT. He's our local expert in Singapore on OCT, and I'm also very eager to hear what he has to say. And we all know Arun very well, and I'm also very eagerly awaiting to listen and critique on his case sharing. So if you allow me, shall we just start and have Chee Yang start on his lecture on the basics of OCT. Chee Yang, please.
Thanks.
Thank you.
Thanks, Jack, and thanks our colleagues from Bangladesh, and thank you for this invitation. I am sharing my screen now. I hope you can see it. So I've been tasked to talk about OCT, optical coherence tomography, the basics, and some techniques or applications in daily practice. So I understand from the introduction that this is not a device that is widely available in your country. I think it's coming. So maybe it's some basic knowledge of how it can help or how it's different from other available imaging modalities would be useful. So just to cover a few very technical aspects of OCT. So the basic concepts of OCT are similar to IVUS, but instead of using ultrasound, OCT obviously uses infrared light or light waves. Yeah. So the idea is that there are light waves transmitted from the catheter, which bounce back off the plaque, and that those reflected waves get received by the transducer, and it gets processed into an image. So that's similar to IVUS. What's different from IVUS, one of the things that's different between OCT and IVUS, intravascular ultrasound, is that light waves are attenuated by blood, meaning that blood absorbs light. So if we were to shine light or OCT into the blood vessel, we actually won't see very much because all of this energy or all of these light waves will be absorbed by the blood. So we need to clear the blood, we need to remove the blood from the vessel, and we do that by the injection of contrast, yeah, or something of a fluid that can clear the blood away from the vessel. Usually contrast, sometimes dextran, and sometimes saline might be good enough. So we got to remove the blood so that it doesn't absorb the light waves. So OCT has a much higher frequency compared to IVUS. So with higher frequency, we get higher resolution. So OCT, we have a resolution of up to 12 to 18 micrometers compared to IVUS, which can only distinguish objects at about 150 to 200 microns in distance. OCT also has a much faster pullback, more than 20 millimeters per second. So we can get a full survey of 75 millimeters in less than 3 seconds. Whereas for IVUS, the pullback is quite slow, as you know. Up to 1 millimeter per second for most of the conventional IVUS machines. And for a full pullback, that takes up about 100 seconds. That's more than a minute. So OCT is much faster. And of course, the OCT software is much more refined. You have a lot of automated analyses that can be done by the machine, which doesn't require too much of our user interference or adjustment. So where IVUS is stronger is that there is greater tissue penetration. Because of the longer wavelength, there's greater tissue penetration with IVUS, so you can see more of the vessel and more of the plaque, if you like. Yeah, there is no requirement for blood clearance, so we don't need to give additional contrast for IVUS as opposed to OCT. And there are a few other technical aspects of IVUS which makes it a little bit more versatile, a little bit more useful for a wider range of use. So these are two examples on the left, an OCT image with very good blood clearance. So when there's very good blood clearance, you can see a very clear black lumen, and you can see the vessel wall very clearly. On the right, you have a very poor blood clearance where the contrast may not be contrast injection is not good enough. So you get all these lines inside the lumen, and all that is blood that has not been cleared properly by your injection of contrast or saline. So as you can see, that interferes with the way we can assess the vessel. So blood clearance is very important. And the best way to achieve that is through contrast. So how do we obtain a good OCT picture? So we got to select a guide catheter that is good, that is well engaged. Yeah, obviously not too deeply engaged either. Otherwise, you get complications associated with that. We got to get good guide catheter engagement as well as alignment. You want to have an adequately sized guider, so at least 6 French, 5 French. I'm not sure the OCT catheter is compatible with that, and even if it is, it's very difficult to achieve a good enough injection with that. So at least 6 French, 7 French may be even better. In vessels where, for example, the left coronary system, sometimes using a guide extension catheter might allow you to selectively inject into your LED or circumflex, so that may give you a better image. If you have a power injector, that is ideal, but I understand that most hospitals or many hospitals may not have this, so you have to use your hand to inject. So if you were to use hand injection, you have to make sure that you can inject hard and at a steady force, because you need to clear the blood very well in order to get a good image. So this is the previous generation OCT catheter, which is the Optus catheter. It has 3 dots. A distal dot here, which obviously signifies the distal end of the catheter. So you got to make sure that this dot doesn't go past your distal end of the wire, obviously. This middle catheter is the imaging, is the camera basically. Yeah, so that's where your pullback is going to start. With the newer generation Opstar catheter, this distal catheter, this distal imaging element is a lot closer to the distal tip. So there's less of a dead space, okay? And this number 3 is the proximal end of the pullback. So it gives you an idea of where the pullback is going to end. This is for the 54 millimeter pullback. With the older catheter, you also have a 75 millimeter pullback, so that can go even further back. Okay, so you can position your OCT catheter adequately in order to cover your lesion of interest. So how do we reduce or optimize contrast use in OCT? There are a few techniques, obviously. One is to use a guide extension catheter for selective injection. Show an example here. This is an LED assessment, and we have a guide catheter sitting in the LED, which you can see. And it selectively injects contrast into the LED. So there's less contrast that is required to be used because we don't have to shoot unnecessary contrast into the circumflex. If you don't want to use contrast in patients such as those with severe kidney disease, we can use saline as well, but the blood clearance of saline is not as good as with contrast. In the past, we tended to use dextran, but there are some reports that dextran also increases the risk of acute kidney injury and also increases the thrombogenicity of the blood. So dextran is, although it's possible, it's not very popularly used at the moment. Obviously, you also want to avoid using a sidal catheter, otherwise you waste contrast going into the aorta. And other ways is to reduce the number of injections. For example, after POBA, if you want to, a lot of us after ballooning, we take a test shot. But instead of doing that test shot on its own, we can do it with the OCT, so we can combine both angio and OCT at the same time. So for OCT pullback options, there are usually 3. So there's a survey mode, which is the longer pullback, 75 millimeters. It's a fast pullback. So this is the one that I said will be done within 3 seconds. And this is the one that we use clinically most commonly, okay? Because it gives us more than enough information that we need clinically for stent sizing, for stent placement, etc. There's a high res or high resolution mode. This is a 54 millimeter, a shorter pullback, but it pulls back slower. So it samples more per millimeter pullback. And this is mainly for research purposes. If you really want to get down to the detail of what the vessel is showing, then we use this. But for most clinical cases, we can use the survey mode. The stationary mode is where the OCT doesn't move at all. The camera doesn't move, and you just inject contrast. So there's no pullback. It's a static assessment of that point in the coronary artery. So this may be useful in circumstances such as myocardial bridging, but otherwise this is not very clinically useful. This is what the OCT interface will show. It's a lot of information, but a lot of it is very useful. So here in the top right-hand corner, it's got the cross-sectional view of what is happening there at the level that you're assessing. This is the advanced view of which you can toggle between different screens. The most commonly used is this angio co-registration. So where this white rectangle is corresponds to where you are in the vessel and tells you where the cross-sectional area is. So you can co-register what you're seeing on OCT with where you are in the angiogram. Here's the lumen profile. It gives you an average of the cross-sectional areas and lets you identify quite quickly where the minimum lumen area is, where the tightest area is of the vessel. Down here is the L mode or the longitudinal mode, and that allows you to assess the longitudinal view of the vessel as well. So in terms of image interpretation by OCT, it's not dissimilar to IVUS. A lot of it is actually very similar. These are the common things you have in the central imaging core, which you also have with IVUS. You have the guide wire artifact, which you also have with IVUS. So every image will have these 2. And then we have here this black space, which is the lumen, all right, which you also have in IVUS. Then we have the vessel, all right. So it's important to understand that the vessel or the coronary vessel has 3 layers. We have the media, which is this black or darker band, yeah, over here, which you can probably appreciate better in this zoomed out image. This media layer, this middle layer, this darker layer is bound by an internal elastic membrane as well as an external elastic membrane, otherwise known as internal elastic lamina and external elastic lamina. The terms are interchangeable. Anything on the inside of the media, of the internal elastic media, is the intima. So this is the intima, and this is where most of our plaque develops. So our fibrous plaque, lipidic plaque, calcific plaque develops in this intima. Here, this is a segment of normal or relatively normal vessel. So the intima is thin. So there's not a lot of disease. There's not a lot of fibrous thickening. So this is quite a healthy part or healthy segment of a vessel. Anything on the outside is called the adventitia. For the purposes of intravascular imaging, adventitious for OCT anyway, it's not so useful. So what's most useful is the media, identifying the media first, and then assessing the what's in the intima. So I'll give you a few examples of the types of plaque that we can identify on OCT. Here we can identify fibrous tissue. So first thing, as I mentioned, to do is to identify the media layer, which is this dark band that hopefully you can convince yourself is going around this vessel over here, okay? And then anything on the inside, on this edge, there's some thickening, of the intima, okay? This thickening is homogeneous. It is almost equally bright. So this is what we call fibrous tissue. Here we have an example of lipidic tissue. Lipidic tissue on OCT tends to appear dark and diffusely dark. And it attenuates light, attenuate meaning it absorbs the light energy. So light not only doesn't bounce back, but it gets absorbed, so it cannot penetrate through. So here we get, we can see that the media is on this side, but when it gets to around this area, we don't see very much of the media anymore because there's this layer of lipidic plaque which absorbs the light and doesn't allow OCT to penetrate through. This is another example, and here we have an example of what we call thin cap fibroatheroma, or in research terms, we call it TICFA, TCFA. This is where there is lipidic plaque, as denoted by these white asterisks, and they are very close to the lumen. So the fibrous cap, or the cap for this lipidic plaque, is only very thin. When the thickness of this cap is less than 65 microns, we term it to be TICFA, or thin cap fibroatheroma. Here on the right image, we have lipidic plaque as well, but you can see that the area of fibrous or the thickness of fibrous plaque is a little bit more. So this is thick cap fibroatheroma. So thin cap fibroatheroma is a little bit more vulnerable in the sense that it is more prone to rupture, prone to causing MI or acute coronary syndrome, whereas thick cap fibroatheroma is deemed to be less vulnerable. Calcium also appears dark or hypoechogenic, but compared to lipid, it has very well-defined borders. So this is, you can almost use a pencil and trace out the edges of this calcific plaque, okay? So this is the calcium plaque. It is dark. It is fairly homogeneous, but the light can penetrate through it. So it is not attenuated by the calcium. It is not absorbed by the calcium. So the light energy is still there. It is able to penetrate through the calcium and still reflect to some extent. And that's why we can see the deep surface of calcium. This, of course, is in contrast with IVUS, or intravascular ultrasound, where all ultrasound waves are reflected off the surface or off the superficial surface of the calcium. And so we get an image which is something like this, where we have a bright leading edge, but we cannot see anything behind it. So we don't know the thickness of calcium on IVUS, but we can tell it on OCT. There are different ways to describe calcium. We can describe it as eccentric, where it's less than 360 degrees, or concentric, where it's 360 degrees. Superficial, where it's close to the lumen, or deep, where it's not so close to the lumen. So these are just terms to help people understand how the calcium is distributed. Calcifying nodule is something that is gaining some interest. It is not commonly seen, but it's also not uncommon, and it can provide a challenge to our angioplasty. Calcified nodule is basically tiny little nodular calcifications that protrude into the lumen. Okay, so Contrast this to the usual calcium plate, which is part of the intima. These calcific nodules protrude into the lumen, and they also have thrombus, tiny bits of thrombus and fibrin that that are on the surface of the calcific nodule. Yeah, and usually at the bottom of it there is a calcium plate that you can't see. So the OCT calcium score is something that was described a couple of years ago, and this allows us to assess based on OCT how difficult it might be to prepare or to treat a lesion with heavy calcification. So the OCT calcium score is an objective measure of how difficult an angioplasty might be. And it encompasses 3 assessments, which is the arc, the total arc of calcium. So if the maximum arc of calcium is more than 180 degrees, you get a certain number of points, which is 2. If the maximum calcium thickness is more than 0.5 millimeters, then you get a point. And if the total length is more than 5 millimeters, you get another point. And basically, the more points you get, the harder it is, or the more difficult it might be to get a adequate stent expansion. And the idea being, if you have a very high OCT calcium score, such as one that is 4, then you might need to consider, or you should consider, the use of calcium modifying device such as rota or orbital atherectomy or lithotripsy. Just show you some other kinds of examples of what we can see on OCT. Here's an example of thrombus. You can see that there are these bits which extend into the lumen. The surface is very, very irregular. Yeah, so this is thrombus. When it's a little bit hyperechogenic like this tends to be a little bit more chronic. So this is more likely to be white thrombus. Red thrombus is usually very bright on the surface, yeah, and also with a very high attenuation. Okay, so this is thrombus inside the vessel. Here is an example of a plaque rupture. These are still images. The asterisk indicates the necrotic core that has recently ruptured and caused an acute coronary syndrome. You can see that there looks like there's a hole, yeah, inside the vessel. So this little hole or this little cavity probably contained lots of lipidic and highly thrombotic material. And when it ruptures, it becomes a nidus for thrombus formation and causes an ACS. These are other things that we can see on OCT. Here are some microchannels. You can see these tiny little black holes. They represent tiny little channels inside the intima. And this is another sign of plaque vulnerability. So there are a lot of things that we can see in terms of the plaque on OCT that can, help us identify whether a certain type of plaque is high risk or not. This is an example of a patient with a spontaneous coronary artery dissection. So here you can see that the vessel is quite intact, yeah, but soon you will see that there will be a separation here of the intima away from the media. Okay, so you can see that there's now the intima or the lumen, in fact, is now squashed, right? It was prior to this quite big, but it's become squashed, it's become obliterated by this huge hematoma around, okay? And this goes on all the way, yeah, during the pullback. And this was a young lady who had acute chest pain with a mild elevation of her troponins. And her angiogram looked, otherwise okay with TIMI-3 flow, yeah, but OCT showed this spontaneous coronary artery dissection. Post PCI, we can see stent struts. These are what stent struts might look like, quite easy to identify. Metal is very highly reflective of both ultrasound as well as light. So we get a very bright surface with these so-called spokes behind them. Yeah, of course, they're not really absence of anything. It's just because the light, all the light is reflected off the surface of the stent strut. Therefore, we don't get any signal behind it. So it looks black. Yeah. This is what we call, this is what we see with BRS, bioresorbable scaffolds, maybe not so relevant these days, but it might make a reappearance in future. But with bioresorbable scaffolds, we get these tiny little squares. So instead of the metallic spokes, we get these tiny little black squares. They are radiolucent, so we can't see them on angio. And on OCT, we see them as these boxes. We can also assess for expansion. You can see on this longitudinal view, quite obviously that there's a severe underexpansion of this stent. The OCT machine also allows us to also automatically assesses malapposition, the degree of malapposition. So if you look at this view down here in the longitudinal view, these red dots indicate that there is malapposition in this segment. And when we look at the cross-sectional view, indeed, there is malapposition, meaning that the stent struts are not in contact with the vessel wall. So I'll just show you some images to correspond, what OCT and IVUS might look like. You might be more familiar with IVUS. So this is on the left, obviously IVUS, on the right, OCT. And these are co-registered images, meaning they're from the same cut of the vessel, just using two different modalities. Okay, so this is relatively healthy. On IVUS, we can see media as the black rim, thin intima and adventitia. And on OCT, we can see more or less the same. Fibrous tissue on IVUS versus on OCT. Lipidic tissue on the right. On IVUS, also it looks dark, but IVUS has greater penetration and it seems to be able to still see the outer border of the vessel, whereas on OCT, we can't quite see the outer vessel of the outer border of the vessel on the side with the lipid. Calcium on OCT, on IVUS, we can't see anything beyond the surface of the calcium. On OCT, we can see the deep surface. OCT gives us a lot better resolutions. We can see things like tissue prolapse, which on IVUS, we probably wouldn't have noticed it. And there's some other features on OCT. Again, you get a distal flap, which on IVUS, you really, would be trying very hard to convince yourself. And without OCT, you probably wouldn't think that there's very much here. How do we optimize PCI using OCT? I hope Dr. Arun's talk will touch a little bit on this. But there's this algorithm called MLD Max, which the Abbott team have come up with. So MLD is for the pre-PCI strategizing or pre-PCI planning. So M stands for morphology. So we search for things like calcium, how difficult it might be to predilate our vessel. We can use OCT to assess length. Length to determine what size of balloon and what length of stent to use, the diameter to assess the diameter of the stent that we need to use. And after stent implantation, we can use the algorithm of MAX, where M is medial dissection to address whether there's any significant dissection in the distal edges, apposition, how well the stent is opposed, and also expansion. So all this can be assessed by OCT. So in summary, I think OCT provides very high resolution intravascular imaging, gives us a lot of very clear and unambiguous images. I think with IVUS, we have a lot of the time we try and guess or try and convince ourselves, oh, this is this or this is that. But with OCT, the images are so clear that usually they're unambiguous. OCT is, I would say, is superior over IVUS in terms of image clarity. Pullback is much faster. Calcium is better assessed, and the automated or semi-automated interpretation functions, the software of the machine is definitely much more advanced than any IVUS machine. Obviously, the limitations of OCT are in the fact that it requires blood clearance, so you need to use additional contrast. Alternatively, you can try and use saline, but sometimes the image quality is not that good. So I would say IVUS is still probably more versatile than OCT. For different lesion subsets. Intravascular imaging, in particular IVUS, has been proven to improve clinical outcomes. I think the ultimate trial and IVUS XPL trials in the recent years have proven that in randomized patients, those treated with intravascular imaging or IVUS have better outcomes. And so we probably should, if it's available to us or financially is viable, we should probably use it more frequently in clinical practice. That's all I have. Thank you very much.
Thank you, Dr. Chee Yang. Excellent presentation. You touch all the basics and techniques. I think already he is senior consultant of National Heart Center. I think this lecture and reach out archive also, our big archive, Hello YouTube channel. I think younger fellows can read this lecture in this channel, our channels. Professor Wadud sir, please a few comments and discussion our panelists.
One comment I will make about this lecture is as good as the OCT itself. Very clear, to the point, and with clear demonstration what OCT can actually show. And I really hope that OCT will be widely available in this country. I think next, when we'll be seeing the live cases, then we'll be understanding how much useful this modality of imaging can be for us.
Thank you. We are in the learning curve in Bangladesh. OCT is the study we are studying in the last 2 to 3 years. So this lecture will enrich our knowledge. I see lots of faculty here. Start from Professor Mustafa Jaman. He's the Professor of Cardiology of Bangladesh Sheikh Mujib University. Professor Mustafa Jaman, any comments?
Thank you, Professor Mustafa Mohsin. Actually, the nice presentation. I've learned many things from the presenter, and really he has explained very meticulously and very simple presentation. And I think everybody should learn from this lecture. My question to the presenter that I know that ACC and AHA guideline, most of there is no class 1 recommendation for PCI, but especially for late-main disease and multivessel disease. My question is to how many cases they have used this OCT or in their study actually. Actually, we are doing, Dr. Mohsin also mentioned that we are in the learning curve, and though we are using in cath lab, especially our few center, but in abroad they are using randomly, so far I know. But my question in ACC and HA guideline, very few cases actually. There is no class 1 indication for PCI for late-main and multivessel disease. So can you recommendation or can you express your opinion in this regard, please? How many cases they have used this OCT or IVAS, and why they recommend for CABES most cases?
Okay, thanks. That's a valid question. I think obviously guidelines have to be based on trial data, and I think historically there's been not a lot of randomized controlled trial data for intravascular imaging, and that's why up until now the highest recommendation for intravascular imaging is for IVAS, and that's also only a 2A, not a class 1 indication, but a class 2A indication for PCI, for the use of IVAS in guiding PCI for left main interventions, as well as cases of stent failure. There is no mention of OCT in these trials because OCT does not have its own randomized controlled trial data that is published yet. Obviously, there are trials ongoing, such as the Illumian 4 trial, which hopefully should give us some information in the near future about whether OCT does lead to improved clinical outcomes. But I think in the last 2 or 3 years, there have been some improvements or some breakthroughs in terms of randomized controlled trial data. We have the Ultimate trial, which is from China, and the IVAS XPL trial, which is from Korea. And both of these are randomized controlled trials looking at the use of intravascular imaging, the use of IVAS to be precise, the use of IVAS routinely in guiding PCI. And both trials have very similar findings in that IVAS does reduce the incidence of target lesion revascularization as well as MACE when used in a fairly routine point of view, so not just in left main. So I hope and I expect that the guidelines should improve or change in future, to have a stronger recommendation for intravascular imaging in terms of guiding our PCI. Your next question was about whether or how many cases we use IVAS and OCT in I guess in my center. Here, obviously, perhaps similar to your country, we have financial considerations, so we have no possibility of using IVAS or OCT in every single case. I know there are countries such as in Japan or Korea where every case is guided by imaging. So for my country, I would say about at most 15 or 20% of cases would be guided by imaging. So that's either IVUS or OCT. And I would say that most people are more familiar with IVUS. So the IVUS share of that 15 to 20% is probably greater than the OCT share. Personally, I'm quite comfortable with both. But I do find that IVUS maybe is a bit more versatile in certain, meaning that it can be used in more a wider range of cases. So I also probably use a little bit more of IVUS than OCT. Yeah, but there are certainly a lot of cases where OCT provides you with much clearer information that that IVUS cannot provide.
Thank you.
Thank you. I think it is the good friend of operators. All the imagings. Only constant is the financial constants. Dr. Kalyanasundaram, can you hear me? Dr. Kalyanasundaram, I think we go to Professor Amol Chowdhury. He's the professor of cardiology and ICBD. Professor Amol Chowdhury.
Thank you, Mohsin. Thank you, Wadud and IPDI to invite me as a panelist in this very updated presentation about OCT. Dr. Chin is excellently present. The very complicated basic thing is a very simple way. I again like to thank Dr. Chin. One thing is that there is small comment because we are now using in our institute both IVUS and OCT. We feel the except cost, definitely OCT is superior in some aspect to the IVUS. So I think the last cath lab, I missed the tissue collapse in IVUS due to slow flow. But when I did the OCT, I diagnosed definitely that this is a tissue collapse inside the stage start, and I treat it accordingly. So thank you for Dr. Chin, because there is a lot of panelists. They will comment other things. Thank you, Rashid.
Okay, Dr. Arun also waiting. Short comments. Professor Fazilatun Khan. He is doing OCT in the burden. Professor Fazilatun Khan.
Yeah, just for OCT and IVUS, whatever the imaging modalities is there, the thing is that what the presenter has talked about the OCT, it's a fine presentation, I can tell. And to me, it's just like that the two modalities are complementary. We shouldn't compare with each other, that which one is, because in some subsets, obviously the IVUS is better than OCT, and in some subsets, the OCT is better than IVUS. Obviously, the thing is that, what the speaker will say, because FFR versus the imaging modalities. This is also one of the very important aspects, which is creating a disturbance among the interventionists, actually, because it has been in a large 6,000 patients registry. There it has been shown that the more lesions has been detected by the OCT than angiographically. So more stents. But in case of when we are using the FFR, then there is telemetry flow in the angiographically, and also if it is telling no, it's not significant. And in that case, you are not putting a stent there. So this is one thing, that imaging modalities, when especially the IVUS and OCT, when we are using it, then we are seeing the plaques, and we are feeling that it needs to be stented. So here is a debate here, that whether for a lesion like 60% or 70% angiographically, whether we go for an FFR or because it's totally a different functional assessment. One is the functional assessment, and another is the plaque morphology to see. So here, Dr. Chin, what's your opinion in that case? And obviously, OCT is, I think still now, to see the edge dissection, to see the flaps, and also to see the calcium. These 3 points I can tell is really obviously better than IVUS. Thank you.
Thank you. Our senior panelists are waiting here. I think we go to the Dr. Arun Kalyanasundaram, then hear from the AQM Reza and Khaled, Mohsin Ahmed. Dr. Arun Kalyanasundaram, can you hear me? He's the CTO master, and you already know it. He's the CTO master, and also complex angioplasty and director of Umud Hospital, and good friend of Bangladesh and IPDI Foundation. Dr. Arun, please, you show your live inbox and OCT.
Okay, first of all, guys, thank you so much. That was a very tough act to follow, Dr. Yang. That was great. I really loved your talk. I think you broke it down to the basics. Two things. One, I mean, in terms of disclaimer, I didn't realize that OCT was just making a segue into Bangladesh. So I just added a couple of things, and I, just thought in case Dr. The first talk, we missed out certain things that we could add it here. So I'm going to skim through some of the slides, and then I'll go to the case. Since it was OCT and beyond, I thought and I'm always kind of expected to show a CTO. I actually have a really nice DK crush, but didn't, with OCT, blah, 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 but, maybe for next time. So it's not meant to be an exhaustive overview, but I mean, I think we've kind of touched upon this, right? We really don't want to do bad vessel prep, and you want to, see how OCT is used for assessing a lot of stuff. I think the MLD max has already been discussed, so I'm going to skip a lot of these. I'm going to stop at a few slides here. So one, I think for the most part, you should image both before and after. And, cost issues aside, I think, the patient deserves the best chance. So you should try and do it always. So again, physiology and OCT are not, that was a great question. I think Dr. Khan just brought up. So that's something that people have to be cognizant of. When to use physiology and when to use imaging. So I'm going to skip all this because MLD Max I literally added it during the last talk because I wasn't sure how much it was going to cover. So I will skip through all this, but in essence, right, it really helps you plan your stenting. So we talked about morphology. The next one is the length, and the next is the vessel diameter. So you want to understand all of this before you start laying metal. And then the other one is to look for complications. So we've also talked about that. So I'll kind of skip through all this and get to the case because that's really what you guys wanted to see. So I actually took my OCT basic talk and I just added it to this in the just in case. So it's also important. I'm sure the experts here know that people need to understand what is apposition versus expansion, etc. And what are some reference values? The OCT kind of makes it idiot-proof in a way. So here is the thing, like the pre-PCI run really helps determine strategy. Post-PCI allows for stent optimization. Really, in a nutshell, that's how you guys should probably remember it. For those that have co-registration, super useful, but you can still do it without. So I'm just going to say, it's a super important tool. Now, why does all this matter? Especially when we talk about complex PCI, we want to stent it, lay metal, and get done. It's because you really want to think about long term, and you don't want to end up with vessels like this where stents are grossly undersized. And optimizing it. We talk about, hey, is surgery better, is PCI better, etc. Unless and until we do a good job of PCI, we can never go toe-to-toe with surgeons, especially with the Lima. So here is just an example of a case, and then I'll actually go to the case in box. This is a RCA. There was a long RCA CTO segment. Distal vessel was okay. Collaterals, we had options. Its proximal cap was unambiguous. And I kind of thought, okay, typically you will see, as you guys get more exposed to OCTs, you will see OCTs used for, picking up dissections, thrombus, in MI situations, in definitely in bifurcations, left main PCI. The one area where it's super underutilized is probably CTOs, and probably for good reason. But I thought, okay, let me just show a case there. So anyways, in this particular case, the plan was wire escalation. If it didn't work, retrograde, and if that didn't work, to go ADR. You guys can already see here that it's a post-cabbage patient, as you can tell from the sternal wires. And there's a stent there that's horrendously undersized, or actually underexpanded. So that's probably because they didn't prep the vessel in the first place, et cetera, et cetera. Anyways, so in this particular case, I'm not really focusing on the CTO part. I actually ended up crossing this antegrade with the stiff penetrative wire because we had a stent to guide us. Wasn't that hard. And then there was a lot of vessel prep because if you're going to lay more metal down, you better make sure that things are good. So this is the part where I do want you guys to focus on. You got to be sure that you prepare. I mean, especially when you have a stent failure, etc. And this is your second chance. So you want to be sure that you do a good job of preparing the vessel before. I mean, the first question is, are you going to walk away with DCB, et cetera, or are you going to put in more metal? And again, I think that's always a 50-50. There are some people that would say, hey, never a second layer of metal. I think it's not yet set in stone. Sometimes you end up putting in a second layer. In any case, so after it was prepped, you can see all the cracks in the calcium and that the vessel, even outside of the stent, has been really kind of beaten up. And for this, again, you can use a plethora of vessel prep things such as, real high pressure balloons, such as the OPN. You can use IVL, whatnot. And here was the post PCI segment, OCT run rather. And, since this is not the real live case, I will kind of just skim through this. And what I do want you to know is just make sure you check it, make sure you have good stent expansion, and that it's obviously well opposed. Here it would be opposed. This is the fly through that we I think that was talked about. So it's kind of a cool fancy thing, but you could kind of really kind of fly through the stent and see how things are. And this I find, not so much for this particular case, but when you're dealing with left main bifurcation and want to see the strut, etc., it's useful. It's kind of a cool toy. You could stop it, move things around, etc., and really understand how and where you're crossed. So anyways, that's just a fly through I wanted to show. And this was the OCT run and the final result. So just to rehash the key points, there was an underexpanded stent, good vessel prep, cracked the calcium, which was the reason why it didn't expand fully in the first place. And this is post stenting again. So that's kind of how we started. That's how we ended. So now let me go to the live case. I tried to add it to here, but I couldn't add it to the PowerPoint, and it just slowed down the whole thing tremendously. So give me 1 second. Okay. Where am I? There we go. Screen, desktop. Okay. All right. I think you guys can see the screen. So I will not take 39 minutes, I promise. But here again, this is a young guy, 37-year-old, unfortunately has already had bypass. This is an RCA CTO. There was a graft, but that just supplied one of the vessels. And the guy was just basically floundering around, and he still had pain. So here you could see that there was a graft just to the PD, but there's just this big RPL segment that's not revascularized. So the CTO part, given that this was more of an imaging talk, I didn't pick anything crazy. This was something that actually turned out to be, fairly straightforward. It's always hard to show live case in a box because I don't know what are the key salient features and if I should talk or I should let the recording talk. But I will try my best here. So in essence, what we did was decided to start antegrade. But although it was a pretty, I didn't feel particularly that this was going to be a super challenging case. One of the things that I tell people all the time is don't underestimate CTOs and go prepared. It's always better to be over prepared. I did go with bilateral axis, and the graft insertion point was not very favorable. So what do I mean by that? Sometimes you can just come through the graft, flip retrograde and then go back into the RCA of interest. But here, as you can see, the occlusion is here, and you're not really chasing the PD because the PD is already kind of open. And I mean, rather the graft to the PD is pretty good. So what we really want is just this native vessel RCA to be opened, right? So this is not an option going through the graft. Now, you can always try and see if there are any collaterals from the left side, but here I thought, all right, let me start antegrade, see how it goes. And then if that doesn't work, pull out the second catheter from the guide and go to the left and see if there's an epicardial or something that will come through. This patient actually had a CT scan done outside that was totally useless. All they said was the RCA is occluded. In fact, they didn't even say that the PDA part was occluded. So, and given that there was already one CT done, I just said, all right, let's just figure out what we need to do. That's a microcatheter. This was Corsair. I think this was almost like a year plus ago. There's some difficulty initially with wire penetration, but then it really wasn't super challenging. I think my second wire just sailed through, and that was a pilot 200. So the CTO itself was not too hard. Then once this is done here, you can see me advance the microcatheter over the pilot 200, exchange for a workhorse wire, and then comes all the fun work, right? And now we got to figure out how do we give the best result for this guy long term. And one of the key things, and again, this is debatable, it is very, very likely that I went true to true. Now, in a CTO, and this really goes to the point, point that was made about there is no one clearly superior technique all the time, all right? Now, you just got to be careful. Remember, we're talking about using power injectors and this and that, and if you do have dissection planes in a CTO, which you might, injecting super hard is always going to lead to a really bad outflow later because your dissection is going to propagate. You're going to have hematoma at the distal edge of the stent, and it's just going to be a mess. So here again, just took the bare minimum that we needed to, use your retrograde stuff. And then there's a lot of talking here because we finished this live case pretty soon. And then actually what I did was I said, all right, I'm going to image post stenting. So I did take just one shot before, and then once the second stent was placed, so here's the second stent being placed. I'm just going to go forward a little bit here. Stent coming in. Okay, I just used that to figure out where to go. And truth be told, in this particular case, I got a free OCT catheter. So I decided to use it. Otherwise, frankly, for a CTO, typically, I would probably end up using IVUS. So here, let me, now I'm doing all the post dilation because even angiographically it didn't look optimal. So here's what I thought, all right? That's a 3.0, and then I think I hit it with a 3.5 proximal. I thought, all right, this is good enough. But then this is really the teaching of of this particular live case, was not the CTO, was not the crossing techniques, which I'm sure most of you guys would cross in no time. It's about how angiography underestimates, and sometimes we can be fooled because I thought 3.5 was all right, pretty good. And then came the OCT runs, right? So I'll just go there because I think that's way more interesting. So sorry, this is where I was talking to you about. I'm going to keep this volume low. So again, once you, and in fact here, and again, I think they kind of made a point about you could use, I think dextran's fallen out of favor. So you could use saline 50-50 or just that. Here, I just use saline. And it was harder. You got to inject really hard. You got to take a 20 cc syringe, and obviously, the viscosity is lower, so you got to push super hard. And this is the Optus catheter. So once you verify that, everything is good, that your guide catheter is good, you got to make sure that's clearing distally. Otherwise, you're going to get a crappy image. But that wasn't bad. I mean, you can see that this image is not as good as with pure contrast, but gets the job done. So again, this is where I was kind of toying with like using saline many times for OCT. And surprisingly, the images were not bad. There's been like, I think 1 or 2 papers that have come out where they've talked about how the sizing exactly might be different. But for me, hey, this is good. And again, I didn't capture the whole stent in the first run, but I used saline, so it wasn't a big deal. So I used a second run. So so that's I'm just going to increase the volume because I don't want to talk and it's also. So you can see branches, you can see the apposition. And actually, even if you're not super comfortable with imaging, your stent markers is generally pretty good. And you do get an apposition indicator and expansion stuff, etc. So you just need to understand how to use all of these. So the second part, I mean, there was more stent there. So basically I did a second run. I'll just go back and boom. So again, I just used saline as a second run. And as you can see, I just used a survey mode. I wanted to get it. Once again, you got to inject when it, within the 14 seconds. So here, again, this is a saline OCT. And interestingly, go back here. Yeah. So here, I know that I'm not expanded optimally, right? So I actually took a 4-5 balloon and went back and dilated the whole thing, or rather the proximal part, that segment that was under, malopposed. And then I did another run just to, so you got to pull the guide back when you're doing this, because now I really want to ensure that I do capture the ostium. You could use guided catheters, like Telescope has a tip where you can actually image even outside it, but sometimes you don't need to. Using sidewall catheters is super hard because you're going to dissipate a lot outside, and you need to have good clearance of the blood before you do it. And I think the last one I did a 50-50. So I just want to look at the proximal part here because that's the one that was under malopposed. So that was run 3. So here, again, it takes a few seconds to process, and then you can see the whole thing. And now you see that all those areas that were not fully opposed are now much better opposed, and my expansion is like pretty much 90 plus all through. So that was good. And again, if you're worried about a particular area, you can move back and forth, really study this well in detail, and then kind of go from there. Okay. So, and that's applied through. You can stop, you can play around, you can rotate it. You can do all kinds of fancy stuff with the software. I think it's really user friendly. And actually, frankly, you just got to sit down with it for like, maybe an hour or so. And then I think most of us will be very comfortable with this. I mean, we had the opportunity to like use it during fellowship. So it was kind of a gradual thing. But even otherwise, it's not that complex, especially for those that have been using Iris. So this is all done. There was no dissection and life was good. So that's the one that I didn't show you.
workshop, and hopefully this is the first. Thanks again. Well, I'd like to thank all the sponsors and S&P for the companies today. Thank you for having supported. Thanks for.
All right, guys, that was good. Okay. Questions?
Okay, Dr. Arun,
Yeah.
can you hear me?
Yep.
Can you hear me?
Yeah.
During situation, it is easy to pass the IVS catheter in the CTO or OCT. OCT is sometimes stuck, cannot cross the lesion after CTO proper dilation, but IVS can easily cross, sometimes cross easily in situations.
So let me start with a disclaimer. I just want to show this because you don't get to see this a lot. Number two, in this particular case, I got a free OCT catheter, so I used it just for stent optimization. But otherwise, IVUS would have been my go-to imaging for CTO. So I don't want people to go out and think, oh, let's start using OCT for CTOs. It's probably, really not its first or second or third, indication for OCT. But in terms of trackability, I don't think that's an issue. And typically with CTOs, you really want to refrain from injecting until you've stented it. So really, here you're not using the MLD part so much, you're using it more for the max part, which is for the post-stent. Hey, am I happy with how my stents are? Have I done a good job? Have I expanded enough? Are there any dissections? Is there any position? So it's not a question of can it track. But now that being said, it's just a shorter monorail. So it's not, it sometimes can have difficulty crossing, but not just in CTOs. I mean, there are some times where the angulation is really wicked and you might have some trouble. So but there are also other times where, I mean, just think of it as a very soft, short monorail. So all those anatomic factors that are going to make it hard for it to be delivered will make it hard to be delivered. But there are also times when, where it'll just go. Like sometimes, right? I mean, I don't have the Terumo IVUS. I have a Philips Intrasite. And I mean, I love it. It's short tip, so I can use it anytime. But there are times after stenting where the metal against metal is just really hard and it just won't go and it just won't track. So, I mean, you just got to sometimes, maneuver things a little bit and get the job done. So it's not necessarily more or less easily trackable. But you're going to use it post-stenting.
Dr. Mohsin, thank you so much. Professor Khaled, Mohsin, sir.
Yes, Mohsin, thank you.
AQM Reza, sir.
Yeah, Mohsin.
Professor Khaled, Mohsin, sir. Yes.
Yeah. Thank you, Mohsin, for arranging such a nice meeting over Zoom. And regarding the first lecture of Dr. Chee Yang, he depicted very nicely and in a simple manner, but things look very simple from the gallery. But when you are in the game, you realize how tough it is. And Arun also makes the crossing of CTO lesion looks very easy from the gallery, but it's really, he knows that how tough it is and how unpredictable it is. So it is very important. So actually, once you are in the game, you realize. I have a question to Dr. Chin that regarding the cost perspective, the IVUS is definitely a cheaper option regarding the setup and the consumables. So I think in our part of the world, I think we usually opt to go for the cheaper technology. So in this context, regarding the physicians in training or the cardiologists in training, would you recommend that the fellows learn about the IVUS first and then go to master the technology of OCT, or they can go directly to the OCT technology if it is available? And number two is regarding the catheter crossing profile of if you compare between OCT and IVUS, which one do you recommend as the first try in a very tight lesion or a very difficult lesion? So would you like to go for a OCT first, or you can, in those cases, IVUS can be a better option?
Dr. Arun?
I thought it was not for me, but anyways, I'll take it. Couple of things. Number one, I think, if you're training in today's day and age, you should know both. Of course, if you don't have access to OCT, that's, learn the imaging that you get access to. I think that's fair. But it's easy to make the switch. You really should be versatile with both, I think. That's number one. Number two is that, it's not even so much about the crossing profile, right? I just talked about it when I was talking about CTOs and crossing. It's about the problem when you take an OCT catheter into a very tight area is that you will not clear it. So let us say you take it into a diffusely diseased small vessel. When you inject contrast or whatever you try and do, you're not going to clear, because you got to clear the blood around it, right? So if it's very tight, frankly, before you take your your OCT catheter, just balloon it so that you can clear the blood when you inject. Otherwise, it won't clear. You would just be wasting contrast.
Arun, do you think that the OCT technology, if it becomes cheaper and more available, it's going to replace the IVUS in a very short time?
No, I don't believe so. There are some newer technologies where they are looking at marrying even both. I think they're complementary. I think, Professor Syed Rahman kind of mentioned that too earlier. There are certain times where I think IVUS, especially I'm a CTO guy, right? So I typically tend to reach for IVUS for a lot of things. It's much more utilitarian. I can use it in a plethora of cases in CTOs. And for the most part, it gets the job done, right? That's number one. Number two, but now let's take CTOs out of the game, right? You're just doing OCT, and let's say, as you said, the cost comes down and they're both nearly equal. Unless and until there'll still be certain conditions, right? Where you have renal dysfunction, where you have a dissection and you don't want to propagate it. You might say, all right, I'm going to throw in an IVUS catheter. But if you're looking at pure resolution, OCT will kick ass, right? Even compared to HT-IVUS has narrowed the gap a little bit, but OCT any day is head and shoulders above in terms of resolution. So I think that would be critical. And when you're looking at, let us say, calcium, and you want to see, well, how deep is the calcium? And what is going to be my optimal strategy to prepare the vessel? I think OCT will trump there. When you want to look at small, dissections, when you want to look at when you really want to look, I think OCT is going to be better. But I wouldn't say one will completely edge out the other, because they both, in some cases, one is going to be better. In some other cases, the other one's going to be better.
I'm just going to jump in here and echo that. I just want to echo what Arun just said. I think there are two different imaging modalities, which they're different, in terms of how they were conceived, etc. So one is not going to replace the other. So even if OCT was the same price as IVUS, there will be lesion subsets where only IVUS is suitable, and there will be lesion subsets where OCT will be more appropriate. With regards to learning curve, I think the learning curve, in fact, for OCT is probably not so steep, because there is less ambiguity, I think, with the images. If it's a dissection, it's quite clear it's a dissection. Whereas for IVUS, I trained with IVUS first. So with IVUS, a lot of the time you're like, really? Is there really a dissection there? Then, your boss tells you, yes, there is. And you're like, okay, fine, sure. But with OCT, there's often no doubt, is the dissection or not. Yeah. Of course, the question then comes is when you're seeing too much, is this dissection actually clinically relevant? Is it something that you can leave behind? Angiographically, you can't see anything. IVUS, you probably wouldn't see anything. And on OCT, you see this tiny little dissection. Sometimes you see too much. Yeah. So that is, sometimes too much information is also a little bit tricky for you. So I would say, either way of training is fine. I trained with IVUS first, and so OCT became very easy when I learned it. In future, if there's a facility for learning OCT first, I think that's also okay. I don't think you need to go through IVUS before you learn OCT.
I have a question to Dr. Arun. Mohsin, I'm Professor Mustafa Jaman. Dr. Arun, thank you for your nice presentation. And especially, we know that for CTO, you are the master. And in our country, still now, everybody do not do always CTO due to lack of hardware and lot of any other factors. But my question to you, it is very, we know that high rate of strut malposition in some CTO cases also. And we know the bed preparation is very important for CTO and any other cases of PCI. But when you go during CTO due to malposition of the strut implant during stent strut, so what is the tips and tricks? How will actually give some important tips for the our newer colleagues or our upcoming cardiologists who will do the CTO in that scenario?
No, that's a fantastic question, Dr. Zaman. And this is something that we struggle with, right? I mean, number one, these days, I do have a very low threshold for throwing in an IVUS catheter to study the vessel, because many times, these vessels are chronically negatively remodeled and, but like I said, I mean, typically I never throw in less than a 3.0 in the LAD, right? If it's a guy, almost never. It really, you always end up, I think, sizing up a little bit once you image. So, I use that 0.5 factor in case I can image. Number two is, and you can't take the vessel back to how it used to be once upon a time either, because then you run the risk of dissection. So, a couple of things that I've been doing in the last few years. Number one, I only tend to stent what I absolutely need to. And I mean, the distal vessel, many times I just leave it be. Let's see how it grows. Because you're absolutely right. Let's say you put in a full metal jacket and then you find out that you grossly undersized it, or that you just couldn't stent it at that point, just because the vessel will just tear if you take it back to that size. So just stent those areas that are absolutely required. I've started playing a little bit more, in fact, a lot more with DCBs these days. And the third thing, I mean, just as a workhorse thing is if you do stent it, sometimes what I do is just leave the distal edge. I just under deploy it a little bit, then come back. I mean, I'm sure most of you guys tend to do that too. Just come back, and then I have the stent to protect me. So if at all there is an area that I'm kind of not perfect, or really taking it how it originally was, it's just a very distal edge, because that's where most likely you're going to dissect. So again, image, stent only when you have to, use more DCBs. Perhaps you can, just under deploy it a little bit, come back and go back. And then the other thing is, let us say it's a very important, and the good part in our parts of the world, yes, there is cost, but you can also, most of them, if they're your patients, you can always say, hey, let's just go back in a couple of months and see how things are. If you feel like you haven't done a perfect job, or if you just want to check it out, or if it's in a very important vessel.
Thank you. We have one of the versatile cardiologists, Professor AQM Reza, sir. Professor AQM Reza.
Thank you very much for a nice presentation by Dr. Chee and Dr. Arun. My understanding that it is very difficult for someone to understand all the tricks and tips of the IVUS and OCT. So actually, we are the interventionist. We need to see the internal lumen and its surrounding, and put a stent perfectly and very nicely, that without any complication and well expanded. In this situation, I think which one is the best modality for assessing and post-stenting assessment? Is it OCT or IVUS? Obviously, it is OCT, I think. So if you
can you hear me?
I think Dr. Chin was just about to answer.
Sir, you continue, sir.
I'll give my opinion. I don't think it's obviously one or the other. I think both are just as good. I think IVUS is the one with the randomized controlled trial data at the moment. So you can't at the moment anyway say that OCT is better than IVUS.
No, but Dr. Chin, it is very difficult to do IVUS and OCT simultaneously in a same patient.
Of course.
So in that case, which one you will choose for exact stent expansion or stent apposition?
I think it's more than that. I think you have to choose which one is more appropriate for the case in general, because we don't use the imaging, or we shouldn't. You know, as we have mentioned a few times, the imaging catheter itself is expensive. And as Dr. Arun mentioned in his talk, do we use the OCT? Do we use the imaging catheter before or after? We try and use it both, you know, as much as possible. So when we use an imaging catheter, when we plan a case, and we decide to use imaging, we should try and use it as much as possible. And that starts from planning pre-PCI, intra-PCI, and PCI optimization. So I wouldn't use one or the other just for stent optimization and assessing stent areas. So I think it depends on the lesion subset. If it's something like an osteal lesion or a CTO, then these kind of cases, then I probably think that IVUS has probably a little bit more utility than OCT. If it's a case where, you know, an acute coronary syndrome or a case of acute stent failure or stent thrombosis, then maybe OCT can give you a bit more information on the mechanism of what's going on, yeah, of what caused the presentation. Then I would go with that. So I wouldn't use one or the other, or I wouldn't grade one or the other of being superior, you know, in terms of stent optimization. I think both are good, you know, to assess stent expansion, to assess stent apposition, edge dissections, etc. So so that would be my take on it.
Can we differentiate that if we do the left main stenting, in that case we should use IVUS, and if the normal vessel, that is LAD or LCX stenting, then we should do OCT?
I think it's very hard to have a black and white kind of you know, delineation of this lesion IVUS, that lesion OCT. I think certainly for left main there are a few things to consider. Left mains tend to be large, yeah. So when it's a large vessel, sometimes your OCT blood clearance may not be so good, so your image may not be so clear because there's still blood swirling in the left main. Sometimes the left main is large and the OCT's penetration or field of view is not as good as IVUS, so you might not see the whole vessel. Sometimes with left main, you want to, you know, if it's a complex left main, you need to do bifurcation stenting, the recrossing of your wire, and you want to assess, you know, if you're really a high level kind of imaging user and you want to assess which cell your wire has recrossed, then maybe OCT will give you better resolution in that sense. If you're assessing an ostium or an osteal lesion of the left main, then OCT may be difficult. Yeah, not impossible, but difficult. Then IVUS may be superior. So I think there are different considerations. So it's not a clear left main equals IVUS or not. But okay, maybe on the balance of things, maybe there are more considerations, more things which are in favor of the use of IVUS in the left main compared to OCT. But it's not to say that OCT is not possible to be used.
Mohsin,
Thank you.
Mohsin, can I have a question?
Yes,
can I have a heartbreaking realization, or in a real world, that what the Chang or the Arun will say, that a case with obviously with class 3-4 angina, but while doing an angiogram, you're seeing a borderline lesion. Okay, so in that case, whether you will follow the path of courage or the orbiter trial to go for a physiology assessment, or you will go for a imaging to see actually what is the plaque morphology, whether to stent it or not. What is your approach, or how you can define yourself that, yeah, I'm obviously, at least by all the modalities, are correct in a correct way to treat the patient. Both of you. Arun and Shafi.
I'll take it. I mean, so yeah, I mean, if it's, you're saying that, well, you have a clear smoking gun, it's in the gray zone. I mean, I would probably use imaging. I would go for it. I'm assuming the patient's in good medical therapy, you have good symptoms, you have convinced yourself it's good enough for them to go and have an angiogram. There's nothing else. So yeah, I mean, then I'm gonna just make sure I treat it and see, do a good job of treating it, and hopefully that takes care of the symptoms. Because you will go for an FFR, or you'll go for an, no, you need something, you have to go for it, imaging. Because you need an, so whether this, imaging. Because the patient is very much symptomatic. Imaging.
So you'll go for imaging or FFR?
Yeah. Or FFR. Imaging.
So you know that after imaging, obviously you will have to stent it in most of the cases. If you want to stent, then you go for imaging. If you don't want to stent, you go for FFR. This is one sort of, one sort of telling in the intervention world.
Right.
So which one is?
You ask for symptomatic patients.
Exactly.
Obviously, whatever it is, but
you made it a little bit easier for us, Professor Rahman. If you had said the patient's symptoms are kind of like, squirrely, then it would have probably FFR. Yeah. You're telling me that, no, this guy's got convincing angina. So, and if I'm going to pick one, I mean, I'm going to use the one that's going to give me not only data for if I should stent it, because in my mind, there's a 60 to 70% blockage. The guy is super symptomatic and good medical therapy. So there's a very high chance he's going to need something, right? So I'm going to take one thing that's going to not only help me, understand how to stent it, but also after I stent, how well I've stented it. So if I had to pick one, I would pick imaging. But again, I don't know. I mean, you could always make an argument. You could do an FFR and you could still do a post-stent FFR and look for 0.94 or whatever. But I would probably take imaging. Just that's
it will take time.
So in that case, when you are, my next question is, in that case, when you're doing an imaging, you know that sometimes in imaging, whatever you are seeing, like whatever that distal reference diameter, where healthy segments, especially in OCT, you are counting the healthy segment distal reference diameter, and you are putting the stent according to it. Obviously, and in IVUS also, you are seeing that one. In IVUS, obviously, the EEM is better you can see rather than in OCT, because the EEM is not that much distinct. Not always you can put according to that diameter. So which one you will follow? In case of OCT, you will see a reference diameter to put a stent of that size, whether you put the stent according to that size or 0.25 millimeter, at least 0.25 millimeter less in diameter. I usually do the 0.25 millimeter less or 0.5 millimeter. Which one you'll prefer?
So, I mean, typically with I think, there are some certain guidelines for it. So if you don't go EL to EL. So I would probably downsize it a little bit, like, and then stent it. I think, in the only time, truth be told, and I'm just going back to what you asked earlier, is if the patient's symptoms were really iffy, I would have, if I'm thinking, and it really goes back to what you're totally right, because now I'm thinking maybe I don't have to stent this guy because I don't believe him. So let me convince myself that I do need to stent him, and hence I would pick an FFR. The situation you described, I've already told myself, hey, I don't see anything else, and this is the most likely culprit, so I'm going to go for it. But yeah, I mean, I would
now the question is stent diameter. Yeah, a little bit less. Yeah. How much you usually make less in case of IVUS and in case of OCT?
So, I mean, typically don't go EL to EL, and I think with OCT I would go like 0.5 less.
Okay.
What do you do, Dr.
Yeah,
Chen?
I usually do 0.5. And what Dr. Chin, what do you do?
Yeah,
Dr. Chin?
I would go 0.25 or 0.5 less than the distal reference EL to EL. If I can see the EL, then I'll do 0.25 less of that.
And if
I
it's
can
just
only
the
see
lumen, you upsize.
Yeah, if it's just the lumen, then maybe I'll either go to the lumen or that measurement or a little bit higher, so maybe 0.25 higher than that. Yeah, because as you pointed out, we don't always see the yield. Yeah.
Mohsin, it's a practical thing which should be remembered by the fellows all the time.
Yes, sure. Nice. Last comment from Dr. Pudip Kumakar. Dr. Pudip. Last comment from Dr. Pudip Kumakar.
Yes. Thank you very much.
Like to use the imaging.
Thank you very much, IPDI.
Yeah, he's doing a lot of imaging. Yeah. He loves imaging.
Time over the presentation. Because we are in the learning curve for take-off phase of OCT, because the NSCBD have been introduced and we are start to use it. The presenter is excellent. Dr. Arun is CTO master and Dr. Chee also is a good presenter. I have a question to Dr. Chee. Though we know that in post-stenting, max, medial dissection, expansion, and apposition should be accepted, or it would take enough. But if you want to take between the apposition expansion, which one you will take this better? Because sometimes a OL expand may not be OL opposed, or an OL opposed stand may not be OL expanded. Though it is better to take the two, but if do not have the opportunity to take that, which one you will take?
Okay, that's a good point. I think it's important to realize that apposition and expansion are different. Apposition mainly is just whether or not the stent struts are in contact with the vessel wall, and expansion is how well expanded your stent is compared to the reference.
More than 90% expansion of the
reference areas. The next thing I just want to say is that trials have shown that under expansion, so expansion itself is a predictor of stent failure. So things like acute stent thrombosis or ISR. So that under expansion does have a connection with that, whereas a stent malapposition does not tend to be associated with acute stent thrombosis. Yeah, we always get hung up about, oh, we need to get the stent touching the wall. Yeah, but you know, in the context of, let's say, a stent that is in an aneurysmal or an ectatic segment where it's just not possible to get the stent touching the wall, malapposition has never been shown. Acute malapposition, stent malapposition has never been shown to be a predictor of acute stent events. All right, so quite bluntly, I guess, a very, very basic point, very, very simple answer to your question is, if you had to choose between the two, I would choose expansion. So a well-expanded stent will give you technically or theoretically better results than an under-expanded stent. Apposition is maybe not so important. Of course, it would be nice to have as well, yeah, but not as important as expansion if you had to, as you put, choose one over the other. But I don't. Yeah. So yeah, that would be.
I'm not telling the more than less than 300 micron. This is acceptable. I am telling is if it is more than 300 micron. What is your perception?
So yeah, I mean so ideally, like I said, you want both, but I kind of have to agree with Dr. Chin here. You don't. I mean, like sometimes you just can't, right? Let's say. Okay, now let's say, what if you have, again, the devil's in the details. What if you have stent, again, let's actually take a real life situation, right? Say you wanted to stent at the ostium of the LAD, which I think people never actually end up at, right at the ostium. And let's say you have one or two struts that have come into a left main and it's like huge. So what are you going to do, right? I mean, but the stent is really well expanded, you got great flow into the circ, there's nothing there, life is good. Are you going to say, well, I have these two struts, they're not completely opposed, or if you have an aneurysmal segment where you're really trying to get perfect apposition is almost impossible. And in the left main, if I have a stent or two, that's suboptimal, I agree. You should have either gone all the way in, enough room for part and the whole 9 yards, but whatever. Sometimes, hindsight is 20/20. it's better to know when to walk away. And if you had to pick one, I would pick expansion over apposition every time. But yeah, I mean, there are times when you really can't get complete apposition, even, if it's more than 300 microns.
Especially in the negative and positive modeling region, what is we cannot get the total apposition or expansion there. What is your strategy on that part?
Oh, in an aneurysmal segment?
In a especially positive remodeling segment.
Yeah, I mean, let us say you go from, ideally avoid it. But if you had to go across it, I would stent to the distal and the proximal. And if there's a little segment that's, leave it. Not try and oppose that whole area, because that's just going to.
We are always conservative in these 2 points, especially in the remodeling region.
I agree, Dr. Pradeep Kumar.
Yes. Thank you so much. Thank you so much. I think really grateful, Dr. Chee and Dr. Arun Kalyanasundaram. A nice presentation, a great talk, and also panelist. Great discussion today. Also, I thank Vascular and Maximum Pharma with us as a scientific partner. Now, time to conclude. Professor Abdullah Chowdhury.
I think today's session is more for the faculties like ours than for our residents and fellows, because we are now like a young kid in this field. I do hope, as NSTPT has started doing it, we'll be seeing more and more use of OCT, also of IPAS, of all the modalities. And the quality of PCI will improve remarkably in this country in future. And with that hope, we are actually arranging this type of lectures and discussions amongst us. And thank you, our foreign faculties, for their kind participation. I do hope we'll get them more and more, and we get to learn from them again and again.
Thank you, sir.
Thank
I
you,
also
guys.
thank Dr. Jack Tan. We are missing him because he's engaged in the primary PCI. Dr. Jack Tan is our really good friend of Bangladesh and IPDI Foundation. So goodbye, Dr. Arun, Dr. Chee. See you later again.
Thank you for the invitation. It was good.
Bye. Thank you.
Bye. Thank you. Thank you so much.
Bye-bye.
Good night.
Good night. Thank you all the faculty.
Good night, everybody.
Thank you, everybody. Bye-bye. Bye-bye.